Welcome back to IJGC Monthly Conversations, the August Editor's Choice. We are diving into some recent publications that caught our eye. I'm Mariana Gouveia from Hospital 9 de Julho, Américas Oncologia, at São Paulo, Brazil.
And I'm Abou Chakra from Hotel Dieu de France, Lebanon. Always great to dive into the latest research.
Yes, definitely. Today, we are going to unpack 3 really interesting articles from the latest issue, exploring advancements in gynecologic oncology. We will start with the lead article, then move into endometrial and cervical cancer. So, kicking us off, the lead article, which I found particularly insightful, is titled Outcomes of Minimal Residual Disease at Upfront Debulking Surgery compared with complete cytoreduction after neoadjuvant chemotherapy. It's led by Violeta Romero from the Gynecological Oncology Unit at La Paz University Hospital in Madrid, Spain. Rim, this paper really dives into a crucial clinical question for advanced ovarian cancer, doesn't it?
It absolutely does, Mariana. The core objective here was to compare surgical complexity, postoperative complications, and survival between 2 specific patient groups: those who had primary debulking surgery with minimal residual disease, classified as CC1, and those who underwent interval debulking surgery after neoadjuvant chemotherapy with no residual disease, or CC0. Why do you think they specifically chose those 2 groups for comparison instead of, say, comparing CC0 primary debulking with CC0 interval debulking?
That's a great question, Rim. It's a real clinical dilemma. Is it better to push for upfront surgery and potentially leave a tiny bit of disease, or to give chemotherapy first and then aim for absolutely no visible disease? Previous studies might have looked at broader categories, but this paper really tries to answer that specific what's the trade-off question for situations where achieving CC0 upfront is challenging. They essentially wanted to see if good enough upfront was comparable to perfect after chemo.
That makes a lot of sense. And their methods, a retrospective multicenter study across 4 centers in Spain and France, give it some good weight, covering patients from 2008 to 2015. What really caught my eye in the results was the tumor burden. They found that the primary debulking surgery as per CC1 group had a significantly higher rate of peritoneal cancer index, PCI, greater than 10 compared to the interval debulking surgery or CC0 group, 82.4% versus 40.1% respectively. Can you explain what PCI greater than 10 means and why that might be important here?
Sure, the peritoneal cancer index, or PCI, is a scoring system used to quantify the extent of cancer spread within the abdomen. A higher score indicates more widespread disease. So, a PCI greater than 10 suggests a much higher tumor burden. The fact that the CC1 group had a higher initial tumor burden suggests these were likely patients with more extensive disease to begin with, making upfront cytoreduction extremely difficult. Despite this higher initial tumor burden, the study found no statistically significant differences in median disease-free survival or overall survival between the CC1 group and the CC0 group. Median disease-free survival was 16.7 months for CC1 versus 18.2 months for CC0, and median overall survival was 44.7 months versus 49.4 months, respectively. That's quite remarkable given the initial differences in tumor burden, isn't it?
It really is. It suggests that even if you can get to CC0 upfront, if you can get to minimal residual disease as CC1, the long-term survival might be comparable to those who achieve CC0 after neoadjuvant chemotherapy. The study concludes that interval surgery should be considered when achieving absence of residual disease as challenging upfront, especially given the lower tumor burden found during interval surgery. This could potentially reduce patient morbidity too, though they noted the difference in post-op complications wasn't statistically significant in their study. It was 27.8% versus 19.8% for major complications.
And that ties into what's already known, right? Previous studies have also shown that interval debulking surgery can reduce surgical complexity and postoperative complications. The interesting nuance here is their specific definition of minimal residual disease as less than 2.5 millimeters, aligning with the completeness of cytoreduction score. Many prior studies used the 1 centimeter cutoff. I wonder if this stricter definition makes their comparison even more clinically relevant, highlighting that even very small residual disease can have comparable outcomes if that's the best you can achieve up front.
I think it definitely adds precision. It gives surgeons a clearer benchmark. Overall, this seems to reinforce the idea that personalized assessment of surgical timing is key in advanced ovarian cancer, a truly important study.
Agreed. Now, moving on to our second article, which is in the realm of endometrial cancer.
All right, the next article we're highlighting is titled Laparoscopic Treatment of Early Stage Endometrial Cancer, Benefits of Sentinel Lymph Node Mapping and Impact on Lower Extremity Lymphedema. The first author is Juan Casarin, and this study comes from the Department of Obstetrics and Gynecology at the University of Insubria, Faculty of Medicine and Surgery in Varese, Italy. This study looks at a common and significant complication of endometrial cancer surgery, doesn't it?
It certainly does, Rim. Lower extremity lymphedema is a really prevalent complication, significantly impacting patients' quality of life. The objective of this study was specifically to evaluate this lymphatic specific morbidity in the context of laparoscopic management of early stage endometrial cancer using the Sentinel lymph node algorithm. This is important because, as they mentioned, most existing data on sentinel lymph node benefits primarily refer to open or robotic surgical techniques, with limited information available regarding the laparoscopic approach.
That's a crucial gap to fill. They conducted an introspective study on nearly 240 patients who underwent laparoscopic staging. The patients were grouped by their actual surgical staging: hysterectomy plus sentinel lymph node mapping, hysterectomy plus systematic pelvic lymphadenectomy, or hysterectomy only. What were their most striking findings regarding lymphedema rates?
The results were pretty clear. They found that the prevalence of lymphedema was significantly lower in the hysterectomy plus sentinel lymph node group compared with the hysterectomy plus systemic pelvic lymphadenectomy group, 21.4 versus 44.6% with statistical significance. And the multivariable analysis really drove this home. It showed a threefold increase in the risk of lymphedema for the lymphadenectomy group compared with the sentinel lymph node group. This robustly demonstrates that sentinel lymph node mapping significantly reduces lymphatic complications compared to systematic lymph node dissection in a laparoscopic setting.
Wow, a threefold increase in a massive difference. That's a strong argument for wider adoption of sentinel lymph node mapping. I also noticed they mentioned that no significant associations were found between lymphedema and other patient or tumor characteristics. This surprised me a bit, as I thought factors like higher BMI or adjuvant therapy were known risk factors for lymphedema. How does this finding compare to previous research, and why might the results diverge?
That's a very keen observation, and it actually diverges from some prevailing evidence in the literature, which does suggest that higher BMI, extensive lymph node dissection, positive lymph nodes, and adjuvant therapy influence the risk of lower limb lymphedema. The authors themselves acknowledge this divergence. They offer a few postulates for why their findings might be different. First, They suggest the low number of patients in the hysterectomy-only group might have mitigated the influence of comorbidities on lymphedema. Second, most of their procedures were laparoscopic, with a very low conversion rate to open surgery, which might reassess previously noted risk factors that often occur after open surgery. And finally, they speculate that even in the hysterectomy-only group, efforts to locate sentinel lymph nodes might have affected lymphatic drainage. They also point out that the assessment method for lymphedema can vary, emphasizing the need for standardized evaluation.
That makes sense. The minimally invasive nature of laparoscopic surgery might indeed alter the risk profile compared to open procedures. And that's an area where the study really adds to the literature, specifically for the laparoscopic approach. So, the implication here is that sentinel lymph node mapping in laparoscopic early stage endometrial cancer surgery not only has comparable diagnostic accuracy, but also significantly minimizes complications, particularly lymphedema.
Exactly. It supports the growing acceptance of sentinel lymph node mapping as a viable alternative for endometrial cancer staging. And they even suggest that tracer reinjection should be strongly supported in cases of unilateral or no mapping to minimize the morbidity associated with complete lymphadenectomy. It's a clear call for refining surgical practice based on patient outcomes.
Great insights. This one definitely helps solidify best practices for early stage endometrial cancer. And now for our final article, which tackles a really challenging clinical scenario.
Yes, for our last discussion, we are looking at a narrative review titled Inadvertent Cervical Cancer, a Narrative Review, with Dave Viveros Carreño as the first author. This comes from the Centro de Tratamiento e Investigación sobre Cáncer Luis Carlos Sarmiento Ángulo in Bogotá, Colombia. Rim, can you unpack what they mean by inadvertent cervical cancer?
Absolutely, Mariana. It's a critical and unfortunately not uncommon issue. Inadvertent cervical cancer refers to infiltrative cervical carcinoma that is diagnosed only after a patient has undergone a simple hysterectomy for what was presumed to be a benign disease. The authors proposed this term because the diagnosis should never be incidental. It points to a failure in detection and planning before the initial surgery. It's a stark reminder that even with all our screening advancements, cases still slip through the cracks, often due to inadequate preoperative evaluation or missed follow-up on abnormal screening results or insufficient re-excision after conization. Social determinants of health like race, ethnicity, and socioeconomic status also play a significant role in these diagnostic failures.
That's a very clear explanation, and the term inadvertent certainly captures the essence of diagnostic failure. The review then moves into management options, which seem to vary quite a bit. They highlight observation, radiotherapy, or completion surgery. What really caught my attention was their proposed risk-based classification: very low, low, medium, or high risk. Can you walk us through the general approach for each category based on this review?
Certainly, this risk stratification is key to guiding management decisions. For very low-risk patients, meaning those with FIGO stage 1A1 or 1A2 without lymphovascular space invasion, observation may be suitable given their very low rate of nodal involvement. Low risk includes 1A1, 1A2 with LVSI and 1B1 tumors, especially with limited stromal invasion. For these, the NCCN guidelines often suggest additional surgery for lymph node dissection, though European guidelines can be more conservative, sometimes recommending no additional treatment if margins are clear and no LVSI for PT1A2. Medium risk is a bit of a catch-all for patients not fitting other categories, or notably, patients who would otherwise be low risk but underwent minimally invasive hysterectomy. This is a really important point given the discussions around minimally invasive surgery for cervical cancer. And finally, high risk includes larger tumors, greater than 4 centimeters, positive margins, or nodal involvement on imaging. For these patients, chemoradiotherapy is generally the preferred approach.
That makes sense. I saw the mention of the CONSERVE trial in the discussion. It's a very relevant study. The review notes that in that prospective trial, 16 patients with inadvertently diagnosed low-risk cervical cancer who underwent simple hysterectomy followed by pelvic lymphadenectomy had a high recurrence rate of 12.5%. This led to their exclusion from the study. What's the significance of that, especially with minimally invasive hysterectomy caveat you just mentioned for the medium risk group?
That's a critical point, Mariana. The CONSERVE trial specifically highlights the potential issue with minimally invasive hysterectomy in this context. All patients in the trial underwent minimally invasive surgery. While the trial aimed for conservative surgery, the high recurrence rate in the inadvertent group, particularly those who had the initial simple hysterectomy minimally invasively, suggests that the benefits or safety seen with radical open surgery for cervical cancer may not translate directly to minimally invasive approaches, especially when an initial diagnostic failure has occurred. It underscores why the review places patients who underwent minimally invasive hysterectomy into the medium risk category, even if their tumor characteristics initially appear low risk. The surgical approach itself introduces a different risk profile.
That's a crucial distinction and certainly a limitation in drawing definitive conclusions from retrospective data. The review consistently points out the low or very low quality evidence available for managing inadvertent cervical cancer, mostly retrospective studies and expert opinions limiting definitive conclusions. This seems to be a common theme across all three articles, the call for more robust prospective data. What are the key takeaways for practice and future research for this review?
You're right. The call for better evidence is a recurring theme. The key takeaway from this review is that while individualized treatment decisions based on tumor features and patient preferences are currently necessary, clinicians should proactively collect data on clinical decisions, oncologic outcomes, morbidity, and quality of life. The goal is to strengthen the evidence base and guide future management, especially since a large randomized controlled trial is challenging due to the condition's relatively low incidence. It truly emphasizes a pragmatic, adaptable approach while advocating for more rigorous data collection to define optimal care.
That's a solid summary, Rim. It's clear that although we have some guidance, there's still a significant need for more precise and high quality data to truly standardize care for these complex scenarios. Thank you, Rim, for joining me today to discuss these insightful articles.
My pleasure, Mariana. Always a learning experience.
That's all for this episode of IJGC Conversations. Thanks for joining us, and we'll catch you next time.
Bye, everyone. We'll be back soon with more updates from IJGC.